Thank you, Salim, and thank you, everybody. It's an extraordinary honor. I really mean that most sincerely to be here, and particularly to have the opportunity, honor and a surprise to be given an opportunity to talk to an audience in a location such as this. So I will do my best, but my disclaimer at the start is Salim kind of hinted I'm not a vaccinologist and I'm not an infectious disease physician. So I'm coming at this question from a data epidemiology analytical point of view. I'm going to start by pointing to my colleagues, a group of 3 very talented research scientists, either doctoral or postdoctoral. Dr. Paulina Stelik, who has led the review that we're doing at the moment, and I'll explain what that is, featured an earlier slide of yours, Salim, because that systematic review of vaccines and long COVID, she was, I think, the second author on that paper. So I photographed that and sent it to her. She was really pleased. So thank you for that. What we're doing here is what we call a scoping review of the literature on vaccine effectiveness in preventing death. And the backstory is that Australia did a bad job in collecting this type of information, collecting the data and making it available to academics to analyze. And we're producing a kind of playbook for the next epidemic by going through what all other countries did in terms of the literature. So our focus is a bit on data design and analytics, but I don't want to drag you in a dry way through that. So I'm going to digress and look at the actual data as well as how the studies were done. So this is a scoping review, and the protocol is published and it's underway. And it's a slow business because it involves a fairly detailed review of every single paper. The data, the period we're covering is from the start of vaccination through to the first quarter of 2023, and we're focusing here on studies that looked at the impact of vaccination on mortality. And I'll emphasize, I'm going to come back to it, COVID-related mortality, but also all-cause mortality and what that means. It's part of a larger, we're part of a larger network of centres around Australia, Centre of Research Excellence, and the funding to support the scoping review comes from there. The specialisation here amongst the scientists that are part of this network is the use of large, linked, routinely collected health data sets. Now, I would emphasize early on, these are not necessarily electronic medical records with clinical details. These are administrative records that are collected, a diagnosis, a consultation, a procedure, a drug prescribed, and so on, and are linked to the level of the individual and used to make causal inference about the impact of medicines, in this case vaccines, and health outcomes. The plan of presentation, brief review of the data designs and methods, our scoping review, with a focus on real-world data. These are data routinely collected during the delivery of healthcare. They're not a part of a research project. Principal conclusions of some of the systematic reviews. There are a large number of them. I'll pick a couple as examples that I think give a good sense of what's going on. I'm going to emphasize the importance of developing national local capacity to perform controlled studies of vaccine effectiveness. I think there are some strong reasons for that. And the wide availability now of electronic health data, and I don't just mean in rich countries. I'll show you that middle-income countries, high and low middle-income countries performed extremely well during COVID in churning out some really important studies. So the availability of linked electronic health data enables countries to do studies that really weren't possible in the past. Then I'll finish by going and looking at adverse effects, and in particular some of the claims that have been made and the concerns about excess deaths that have occurred following the pandemic. And some of the implications of that have been made that in some way it's related to the widespread use of vaccines. It's not, but we'll go through some of the arguments. and some of the data. So the designs to estimate vaccine efficacy and effectiveness start on the left with the traditional randomized trials, and we heard from Barney earlier on something about those trials, and now they're part of our recent history, those trials. They were covered extensively in the press. We quickly reached a point where we needed a lot of information that was not available from these early randomized trials that could only be collected through observational studies using personal level data that's linked, that allows you to go from exposure to outcome. The other data I'm not going to talk much about, except in relation to adverse effects, is ecological studies, where the data are aggregate groups of data followed over time. These are time trends. That one there happens to be the parallelism between solar irradiation and performance of the New York Stock Exchange. It's just an example of an ecological fallacy. So these three types of studies are all relevant to this. So the trials, they're recent memory, 39, that covered our initial take on how well these vaccines work. Deaths occurred in only 7 of these trials. There were over 200,000 participants in those initial trials. There were 41 deaths in total. And that, if you looked at the control groups in these trials, the control population mortality was 0.03%. Now, nobody has really got the funding to pay for the size of trial that would show a halving of that risk from 0.03 to 0.015%. You're talking about 1 million people in a randomized trial to show that. So it was not possible here to get confident estimates about how well the vaccines worked. But also it shows you that rate was rather lower than was typical in the countries in which the trials were being done. Maybe a third of the average rate at that time, which indicate they were selected individuals. They were really low risk individuals, younger, not much in the way of comorbidity. And here the results are going to be difficult. This is a forest plot. The vertical line that you can see is the null line. That's 0. It's actually 1 in this case because these are relative measures. And listed down there, you won't be able to read the names, are all the trials, and they're in groups according to the type of vaccine, mRNA, protein subunit, viral vector at the bottom. Each dot is a trial, and the whiskers are the confidence interval around that estimate. The thing to look at are these horizontally oriented diamonds. If the eastern corner of those diamonds crosses the null line, the vertical line, it means it's not statistically significant. But if you look at the numbers, you see a lot of those trials had 0 deaths, none. So individually, they could not draw any conclusions. However, if you pull the data, that overall at the bottom, where I've tagged it overall, that diamond is clear of the null line. In fact, it was a significant reduction in mortality when you pull the results from those trials. This was the meta-analysis of Karang et al. But almost all of the statistical weight, 53% of it, was one trial. It was the trial of Sadov, published in New England Journal. It was a single dose of Janssen viral vector vaccine. This gave the impression that perhaps, for a while, I don't know if this is held, that the viral vector vaccines might be better at reducing mortality. This wasn't evidence to really support that. This trial had quite a high, relatively, mortality rate. It occurred in 10 countries, including some that were experiencing quite bad epidemic at the time. But overall, that showed about a halving of mortality, and that's all deaths. But it's in a young, relatively fit population, and it's in a short period of time. So there was a lot that those trials could not do. Really didn't give estimates of the reduction in serious illness and death individual vaccines, specific combinations of vaccines, which quickly became messy from an analytical point of view, and effectiveness in select groups. I won't list through all of these. You can read them quicker than I can. But those that we recognize are vulnerable to COVID. Also you can't keep doing randomized trials for each variant. It wouldn't be ethical. You'd have to do head-to-head comparisons of individual vaccines. The sample size you'd need would be enormous. It really wasn't practical to keep doing trials. So we're quickly relying on observational data, and the trials wouldn't allow you to look at waning of effectiveness. So the important questions that underlie these that have really determined our policies required observational studies, real-world studies, and indeed that's what's happened. This was, just to make a point, not this was an important paper. In March, April 2021, we published a narrative review, I think, of the first 8 studies, 4 of which were in preprint form. The other 4 were peer-reviewed and published, been published very quickly, and gave a very positive review on these early results. These are not randomized trials. These are the initial observational studies. And just to put it in context, when I went back and checked on the 1st of November at the International Vaccine Access Center at Johns Hopkins, there are 640 observational studies now in their database. These are comparative studies of effectiveness of all of the vaccines that have been tested, conducted in 54 different countries. So this is huge. I don't recall, in my time looking at big data, population data sets, I don't recall anything whereby 640 quite sophisticated studies were done in about 3 years, looking at one particular set of interventions, in this case, COVID vaccines. So this is a revolution, and it's a testament to the wide availability of electronic health data and the capacity to use these data properly. And I'll talk about what that means in terms of avoiding bias. So that rapid development of electronic administrative health data linked at person level has really transformed our ability to do this. And we knew this already, but it really just came to the fore during the pandemic. There are really good privacy protection systems in place in most countries. There was a rapid establishment in vaccine and test registries that therefore got integrated quickly. I want to emphasize the improvements in computer and data science. Some of the analysis that we did later in 2023 were so intensive that they would have dimmed the lights had we done it in the past. But with modern computing, we're able to do multiple iterative calculations with extensive adjustments really quite quickly. So the improvement in access to this level of computer and data science, and not just in high-income countries, I want to emphasize that, has really transformed it. So has our understanding of study designs. So much so now that increasingly we use the word target trial emulation. That is, we use designs with the observational data sets. These are already observed patients who've already received vaccines or not, and we can emulate a randomized trial within those databases, and that's being increasingly done. And there are improvements in techniques, but improvements in the understanding of biases, the recognition that not just confounding, which we've worried a lot about, rightly so, but there are design-related sources of bias, particularly temporal biases, which can interfere with our estimates. I'll come back to that. So the designs, they're not a large number that appear in this scoping review. For those that live in this world of vaccine evaluation, test negative studies where you compare people who have fronted up for a test, it's been positive, controls of those that was test negative, and you look at their prior receipt of a vaccine or not. Case control studies, which is similar, can study a more serious outcome, people admitted to hospital or ICU or have died of COVID. Controls, there are different ways of selecting, but usually chosen from a test-negative population, so that you have a positive-negative comparison still in the analysis. As the pandemic proceeded, you could see within the data a shift to using cohorts. That's starting with large groups that had received the initial primary dose, first booster, second booster, third booster, and so on. And using sophisticated methods, as I said earlier, some trying to emulate randomized trials, studying multiple endpoints. And I'll mention here self-controlled case series, which have been used in vaccine epidemiology, influenza, quite a bit in the past, mainly in this literature to study vaccine safety. The aggregate data where you don't have access to person-level data, but you've got grouped data over time. I would emphasize particularly discontinuity analysis, regression discontinuity, where because, say, a policy enables the vaccination of those aged 65 to 69, but those that are 60 to 64 are not eligible, you've got two very comparable groups. And without the individual data, you just look at how many, after a lag time for the, the immunological response, are you seeing an inflection in the group, in the vaccinated group? There are many biases that you'll be aware of, and I'm not going to go through them in detail. The one that's best known is that those who front up for vaccination on a regular basis, particularly in the older age groups, are healthier than those who do not, in a whole range of different ways. And in the case of COVID, their non-COVID mortality is lower. So it's a negative control outcome, in fact. And it's a measure of their healthy phenotype, which includes the use of vaccination. There's also the development of futility. That means during the pandemic, people were becoming sick for other reasons, and there came a point where, and I know one personally, is that he doesn't want reaching the end, doesn't want another booster dose. That person appears in a control group. It makes the control group look bad. Rollout policies obviously might favor early vaccination of those who've got risk factors. That makes that vaccination group look sicker. This time varying confinement, I won't go into that at the moment. Environmental risk is the recognition that time matters because of rapid changes in attack rates, that if you're exposed and non-exposed, vaccinated and unvaccinated, are recruited over different time intervals. The background attack rate of the virus may be very different. So you have to put a calendar date into the model. There's a condition, there's a form of bias called immortal time bias. It turns out to be quite important in this literature. We've found a number of studies that clearly have it, that may not have been recognized. And that's the fact that if your starting time is the start, okay, we rolled out the vaccines for the 1st of February 2021, and your non-vaccinated group are followed from the 1st of February 2021. But there's delays before people get, those that get vaccinated. They're effectively immortal until the time of vaccination. So that inclusion of immortal time actually biases in favor of the vaccine. Competing risks is something that has occurred during later. We did quite an extensive competing risk analysis in Australia. We're analyzing everybody over the age of 65. They had a lot had other significant causes of death. Only 6% of the deaths by the Omicron phase in that study were due to COVID. The rest were due to other causes, and you have to account for competing risks when you're doing the analysis. Now, I mentioned target trial emulation. Just under 10% of these studies used target trial emulation approaches. We're trying to get as close as possible to that ideal of a randomized trial. That was increasing over time, and I think we'll see that. It's not one single method. It respects a number of bias avoidance mechanisms. But the point I'll make is that only 3% of these studies received industry funding. So there's a very large, very important literature about pharmaceutical products, industry products, that wasn't, by and large, was not funded by the industry. I'm not going to spend a lot of time on this. This is WHO's systematic review. All these points at the top are individual observational studies. The higher up they are, the more effective they are, and the red bars represent the confidence intervals for effectiveness. And you can see that they were, these studies, these small dots might represent studies with millions of people in them. We're talking about that. It's not weighted to the size of the dot, because it would be impossible to portray it. But you'll see, as we know, there's a waning of effect, and the blue bars were Omicron, and therefore the waning was greater and more rapid with Omicron. That was for infections in the top, but less waning of effect with hospitalizations and deaths at the bottom. I'm not going to go through this in detail. This is very familiar information for everybody. In at-risk groups, there's large numbers of studies that have looked at specific groups: diabetes, immunocompromised, receiving treatment for cancer, people with other forms of immunodeficiency states, and their immunological studies. And there have been systematic reviews of all of these groups. I think this acceptance, and people are much better informed than me here, that these immunological deficiencies certainly blunted the immunological response to vaccines in terms of serological responses. And what the observational studies show was a smaller relative protection for these individuals. So what might have been an 80% reduction in death in a non-compromised group might be 50 or 60% relative. But because their background risk of dying was so much higher, the absolute reduction in risk is great and still worthwhile, even though the relative reduction appears to be smaller. That was a study, the bottom panel, in Australia. Everybody over the age of 65 was in it. When you looked at, it was boosted with 4 doses. How many did you have to vaccinate to prevent one death? It was 1,458 for the general population over the age of 65, but we had everybody in residential care in a separate group, and you only had to vaccinate 157 to prevent a death there. So it was a 10-fold absolute increase in benefit, even though the relative risk reduction was a little bit less in the residential group. I want to go now to countries of origin, because this is what interests me quite a lot. With the widespread availability of electronic health data, many countries have invested in electronic data hugely. And they've done it for very good reasons to run the healthcare systems. But these data, the secondary use of these data for this sort of work is really important. This is a difficult graph, but I'm just going to show you the rank order. Now, this is just a snapshot. We had a sampling window that stopped about the first quarter of 2023. And ranked from top to bottom, the number of studies, high-quality studies, controlled studies that looked at the effectiveness of the vaccine reducing mortality. And unsurprisingly, at the top, USA, Israel absolutely outperformed in so many ways. Very sophisticated studies, large number for a relatively small country. UK did an excellent job in publishing regularly updated estimates of vaccine effectiveness. Every month it was updated, did a fabulous job. But what I want to point to is the group that's underlying them, and particularly South America, so Brazil, Colombia, Argentina, and Chile. Between them have a population a bit under that of the United States. They did 17 studies between them. The US did 18. So to me, this was a group of countries that had installed these electronic health record systems and really did a fantastic job. Taiwan you won't see on that list because the time window just excluded the studies that came on mortality with the vaccination from Taiwan. It wasn't a deliberate exclusion, it was a time window exclusion. And Australia lags down there, it only managed to do one by the time that the sampling window had closed. But here, middle-income countries, high, middle, low-middle-income countries performed really extremely well in contributing to this mass of information which we base many of our policies. I mentioned the reasons for doing local vaccine effectiveness studies and the fact that it's possible now with these electronic, routinely collected electronic health data. And I've listed some reasons there, and you might be able to well think of some more, but I think it's almost the ultimate test of how your vaccine rollout is going, is to measure how many serious infections are being prevented and how many deaths are being prevented. To do that, you don't just monitor curves. You've got to do a controlled analysis, comparative analysis. It allows you to look particularly at disadvantaged groups. It may be that you're able to generate really important data on vaccines that are not widely used at that point in other countries. Locally sourced data can be used for powerful advocacy because it's locally sourced. This is what we're experiencing in our country. It helps build the local data science and analytical capacity, which can be used for other reasons. And frankly, the marginal costs of using these routinely collected data for this purpose are low, so long as your people well trained to, yeah. I'm going to finish with safety. These are the main adverse effects that have been attributed. Myopericarditis, central venous sinus thrombosis, Guillain-Barré syndrome, and Bell's palsy. And each of these in controlled studies have been shown to be increased, but the rates are low. The one that I think is a bit of an orphan and not been much examined is Guillain-Barré syndrome. This is a post-infectious polyneuropathy that causes paralysis. What I will talk about is all-cause mortality, very briefly. There's been the allegation that this increase in mortality that's been seen in many countries after COVID was due to the extensive use of vaccines. And a number of papers have come out, and even though they don't directly allege in many cases, the implication is that it may be due to vaccines. Excess deaths with high uptake of vaccines, there are a number of reasons for that. It may be catch-up deaths in people who were protected from barrier methods during the pandemic. It may be other reasons which I've listed there, which will be available for anybody who wants to have a look at them. What we found in all-cause mortality in control studies, the randomized trials, was a reduction in all-cause mortality. The observational studies are very heterogeneous. There was a large reduction in all-cause mortality. In fact, that reduction, the red crosses in all-cause mortality, was greater than you could explain from the modeled estimate of what should be happening to all-cause mortality if you had an 80% reduction in COVID-related deaths, according to what proportion of your deaths at that point were due to COVID. And so they're not performing as well as this may be. Residual bias that makes the vaccines look better than they are. The self-controlled case series looking at all-cause mortality, the relative incidence, you'll see that column there, is all less than 1. Again, no increase in these. So, conclusions. It's been historic, consistent findings of benefit against severe disease and death. No surprise, you know that. Residual bias in favor of vaccines is likely for a number of different sources, including what I showed you, that negative control outcome, which is non-COVID mortality being that much lower. That shouldn't be the case. It suggests there's still a residual bias, but it does not negate their effectiveness. The scientific contribution from middle-income countries, I think, has been under-recognized here and really needs to be celebrated. Thanks very much.